Okay, so chapter 4 in the 5th edition is Neuroimaging and Neuroanatomy Atlas, and this chapter did not exist in the 4th edition. So there aren't any learning objectives on the exam study guide that are associated with this chapter. I'm not going to test you on it. You will occasionally see board exam questions about different imaging, and that's why I included this chapter. But you do not need to know it in the depth that is available in the chapter. We're basically just going to go over the different types of, vaguely, the different types of imaging that are used in neuroanalysis. So there are some really cool pictures in the Neuroanatomy Atlas in the book, if you want to take a look at those pictures of different types of imaging. So really, I have some objectives for this lecture, but they're not necessarily going to be on the exam. But I just want you to gain a basic familiarity with the terminology of neuroimaging and maybe talk about a few of the pitfalls of neuroimaging, but describe the orientations of axial, coronal, and sagittal images. So one thing that we talked about in chapter 2 is the anatomical position and the orientations in the nervous system are very much the same as we've talked about since the beginning. But one thing that's a little bit different in the brain specifically, is that as the spinal cord comes up and the brainstem starts to go into the cerebrum, it takes a little bit of a turn, almost a 90-degree turn. And so dorsal and ventral in all the rest of the body are equivalent to posterior and anterior. But once you take that turn, as you leave the brainstem, dorsal and ventral become equivalent to superior and inferior. So the ventral surface of the brain is sort of the bottom surface of the cerebrum, and the dorsal surface is the superior or top surface. And then anterior, posterior stay equivalent to what they are in the body. So just dorsal and ventral shift a little bit. So hopefully that's not too confusing, but in radiology images you'll see them labeled like that. So neuroimaging is relatively recent advancement, and it allows doctors and physical therapists to see information that wasn't available before. So we talked a little bit about how in the chapter 3 in the neurological examination about how different signs and symptoms will indicate lesions in different areas. Well, now they can actually use neuroimaging to specifically find a lesion, which is kind of amazing. But for us as PTAs to have an understanding, a basic understanding of neuroimaging, that's going to allow us to understand radiology findings and communicate with other professionals about neuroimaging results. The other thing that I've run into fairly frequently is a patient will come into me and they'll say, I got my MRI report or my CT scan report from the radiologist and I don't understand it. Could you explain it to me? And so I'll actually take their radiology report and I'll translate it for them into layman's terms. And I'll tell them what the radiologist said. So it's nice to know that terminology. And whenever I get a chance to look at anybody's imaging, I always take that chance because it's a great learning opportunity. So neuroimaging is a view on one of 3 planes, and we'll look at the different images that are in the book. Usually for the brain, we're using CT and MRI technologies to visualize the brain. So CT is computed tomography. It is an X-ray beam that's rotated around the patient, and then the computer forms this 3D image, which is really cool, actually. You can scan right through the image like you're slicing through the brain and see all sorts of cool stuff. It's the method of choice in the emergency department or in emergent situations where they're looking for fractures or other bone abnormalities, or identifying acute intracranial hemorrhage. The main concern is that it exposes the patient to a lot of radiation. They have contrast-enhanced CT when they're trying to detect increased angiogenesis, as in with a tumor, or the breakdown of the blood-brain barrier. So both of those are pretty serious situations. MRI, or magnetic resonance imaging, rather than exposing the person to X-rays, they expose the person to a strong magnetic field. The intensity of magnetic resonance images depend on the presence of hydrogen protons. So a lot of times you're seeing the presence of fluid or water, and water shows up dark on an MRI, except some of the different contrasts that they use, it'll show up a little bit differently. But MRIs generally provide better resolution of nervous system anatomy compared with a CT scan. So when they're looking for soft tissue disease, including tumors, MS, or inflammation, they are using MRIs. So in this picture you can see where they have anterior or rostral, posterior or dorsal, superior is also dorsal, and inferior or caudal. Ventral is the bottom surface of the brain is considered the ventral surface. So once we take that 90-degree turn into the cerebrum, the terminology gets a little bit turned. It gets turned 90 degrees, if you want to think of it that way. But when you're looking at an image, that's kind of what you're seeing. And this is a coronal image. So it's, a sagittal image. It's going right through the sagittal plane. And so we're seeing the corpus callosum there in the middle, and the brainstem, the cerebrum, lots of other cool stuff. Love imaging. Diffusion imaging is a form of MRI where they're using different kinds of applications to evaluate different areas. So the DWI is diffusion weighted imaging, and DTI is diffusion tensor imaging. And I don't expect you to know those, but really the DWI is used when they're evaluating for ischemia or differentiating various lesions. And the DTI is analysis of the water diffusion patterns used to create three-dimensional images showing the orientation of the white matter tracks, and that's cool. Those are the axons and the white matter, the myelin wrapped around them. And so in this picture, also I just think they're beautiful. That's the other thing. But in this picture, when I look at it, just not knowing all that much about it and not knowing how to analyze something like this, the things that I see are that red at the bottom, those are the cerebral peduncles. That's the white matter that's going from the pons to the cerebellum, or the cerebellar peduncles. And there's a lot of information. So the pons is the bridge in the brainstem. There's just tons of information going back and forth from the cerebellum to the pons to help coordinate our movements. And so we get that big, strong red white matter band. And then we see the cerebral peduncles in yellow up at the top, and that's all the information going from the cerebrum to the brainstem. And the other thing that I noticed, which I think is super interesting, is how in the cerebrum we see different things on either side. The white matter tracks are a little bit different from side to side. So even though I don't know how to analyze diffusion imaging, you can pick out some interesting things, but I think it's neat that you can visualize the white matter tracks as they are. And so they're probably, when they're looking for various lesions, they're looking for interruptions in those tracks. So just amazing the new types of imaging that are out there. So contrast magnetic resonance imaging, they use a contrast agent which they inject. They can highlight areas of breakdown of the blood-brain barrier or increased angiogenesis in case of a tumor. Someone with kidney disease, the contrast imaging can be a problem because of the way the dyes and things are processed in your body, and they should be avoided during pregnancy, as should a lot of things, actually. Neuroangiography is a CTA or an MRA. They screen for different types of aneurysms or carotid stenosis or abnormal anastomoses between arteries and veins. The CTA is the one that they use, again, in more emergent situations, and the MRA is performed without injection or contrast material. So it's pretty neat that you can visualize the arteries and veins so vividly. I think that's amazing. So functional imaging techniques, they allow mapping of active regions of the brain, and they actually detect changes in oxygen levels in neurons. So the thing that's interesting about functional MRI studies and functional imaging techniques in general is they really add to the understanding of normal brain function and neurological disorders and rehabilitation, like how is the rehabilitation affecting their brain function. And up until these imaging things were available, there was kind of no way to tell what happened in the brain. A lot of the early neurological studies were done by people who had issues. So they didn't know what part of the brain did what until someone had a lesion in that part of the brain and they could see what was affected by that. Now with functional imaging, you can actually have someone do a task or do a pain-provoking activity or something like that and see what areas of the brain are affected. So that's amazing. And it also allows us to see the degree of neuroplasticity, like how does it change? What areas of the brain are now taking over this new activity after an injury? So functional imaging techniques have some wide-ranging implications for physical therapy treatment in the future. Positron emission tomography, the PET is its acronym. You can measure gamma rays as they travel through cerebral vasculature. So fMRI is considered less invasive. PET is not used as frequently, but they're also the PET scanners aren't as common as MRI scanners. But this particular picture, they're using it to visualize a rather large tumor in the brain. So they measure how fast the gamma rays travel through the different tissues, which is pretty interesting. So in functional MRI, they measure the changes in oxygenated blood flow. So it measures gray matter activity, so the somas of the cells, what's going on in the somas of the cells. And you can overlay the fMRI image with the anatomical MRI image and map areas in the brain, which is super cool. They don't have to inject radioactive isotopes or anything like they have to do for positron emission. And so it's a less invasive technique. So one of the drawbacks of having all this great imaging available is now you know what's wrong in your body, and that can actually cause you to experience more pain and worry more about things. We have this poster in our clinic, and and there's a whole set of materials that goes with it. It's called Don't Be a Vomit, and VOMIT stands for Victim of Medical Imaging Technology. So the whole idea behind this is you shouldn't panic if your spine CT scan or MRI shows problems with your discs, like degeneration, bulges, and tears. Those can all be normal changes, and probably most of us over a certain age have them. Various studies of upper and lower backs in people without pain, that's relevant, they have found that 47% of adults have disc degeneration. Over the age of 50, so between age 50 to 55, 90% of adults have disc degeneration, and these are people without pain. And 48% of people aged 20 to 22 have disc degeneration. So disc degeneration doesn't mean you're going to have pain. It doesn't mean there's a problem that has to be addressed. It just means that you live on a planet with gravity and things are changing in your spine. 53% of adults have disc bulges. Age 20 to 22, 25% of them have disc bulges. So a disc bulge is not necessarily something to worry about unless it's causing you a problem. 58% of adults without pain have disc tears. 29% even had a disc bulge that was deforming the spinal cord without symptoms. So there's no positive link between degenerative changes seen on imaging and low back pain. So you can't blame your neck pain on disc degeneration and bulges. So a lot of people are really pushed for imaging and like, oh, I've got to get that MRI, and that's going to show me everything. And it doesn't show you everything. It shows you what's going on in your tissues, but it does not show you what's going on in your brain. So in the pain chapters, we're going to talk more about pain generation and anti-nociception and what we can do in therapy to address these things. So just because something shows up on the imaging doesn't mean it's a debilitating, painful condition. So I think the availability of good neuroimaging has kind of taken us in a bad place at times. So you can't let that be the thing that causes you pain. That's the message that I like to give to patients. So don't be a vomit. Medical imaging technology is great, but is not the be-all and end-all. So neuroimaging allows an understanding of neuroanatomy that was previously unavailable. It's increasingly being used to demonstrate the efficacy of neurorehabilitation. There's actually, besides neuroimaging, just in general imaging, there's a PT in Anacortes, Anacortes PT, who uses real-time ultrasound to demonstrate the efficacy of therapy by showing actual tendon and ligament and muscle healing. So you can actually see changes on both functional MRI and DTI following OT or PT in patients with cerebral palsy, fibromyalgia, and stroke. So I think that's great that the neuroimaging confirms that the physical treatments that we do actually have an effect on the nervous system. So I love the idea of exercise as medicine, and this is proof that it really works. So knowledge of neuroimaging techniques can be important in individualizing people's treatment plans and optimizing therapy regimens. So it's nice to know that even though it does have its pitfalls, it can really show someone that what they're doing is making a difference. And I think that is really cool.